Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is skin and mucous membrane, and the speaker is Dr. Bhumesh Kumar Katakam. Dr. Bhumesh Kumar Katakam, sir, is an associate professor and HOD of DBL with Gandhi Medical College and Hospital, Telangana. He is also the program director of the Pediatric Dermatology Training Center at GMCGH. He is a recipient of many prestigious awards and honors. He has authored around 10 chapters, published 30 papers, and presented 105 papers in various international and national scientific journals and conferences. We welcome you, sir, for today's session and request you to start the session.
Yeah. Thank you, Sweta, for your kind introduction. Very good afternoon, one and all. So today I'm going to talk about HIV/AIDS and opportunistic infections of skin and its mucous membrane. Whatever the experience or little experience is there with me, I'll try to share my practical experiences. Definitely that will be useful in our day-to-day practice. Before I start, always I start with some brain teasers. We know the William Osler is a great physician. He said that humanity has three great enemies: the fever, famine, and wars. The fever is nothing but disease. Of these, the greatest and the most terrible is the diseases. So that's why God has created a powerful weapon to conquer the diseases and acquire the health for the progress of the nation. So that's why we healthcare providers are the fortunate to have do some service to the nation by providing health. Even the Osler rightly said, who knows syphilis, they knows medicine. But I would say, who knows HIV/AIDS, they knows more than medicine. So not only the academic point of view, the social point of view, and the cultural point of view, we need to know the HIV/AIDS in toto. Because the knowledge in HIV/AIDS is very much essential to every doctor, not only doctor, every person. Because as a healthcare provider or a common people, we may be either affected or infected. So it is the responsibility of every individual to know at least basic orientation about the HIV/AIDS. These are the session objectives. What are the different kinds of infections pertaining to skin, how these will help to predict for the screening of the HIV infection. We know that more than 90% of people living with HIV develop skin and or mucous membrane lesions. This is very, very important. Almost, but how to identify based on the skin lesions, whether they are suffering with HIV infection or whether already they have developed AIDS. That means in early immunodeficiency or in advanced immunodeficiency, that we are going to learn in subsequent slides. So the prevalence of skin manifestations in children living with HIV ranges from 36 to 50%, almost 50%. The identification of certain skin conditions can predict the presence of the HIV infection. And one important point, the 3Ps with A, that is persistent, progressive, painful lesions with atypical manifestations. Always you have to consider beyond the skin, especially in terms of advanced immunodeficiency. That also we are going to see some cases. So coming to the cutaneous manifestations, they are the earliest diagnostic markers, acts as a prognostic marker also. If you see the cut section of the skin, these are the various organs, confined any diseases confined to the hair follicle that needs a specific treatment with a proper dose and duration. And before going to that, what is the importance of skin examination in HIV/AIDS patient? Where during HIV infection, the skin is an organ of major morbidity. Remember, so morbidity is more dangerous than mortality. So always, if you have a sympathy, for example, if any person who is suffering with heart problems, they will have a sympathy. But any person who is suffering with the skin diseases, even the own family members doesn't show sympathy, and they will keep those people in a distance. That again gives rise to increase the severity of that particular disease. So that's why the healthy skin approach is very, very important. How this important? Because the skin can be a portal for opportunistic infections. The healthy skin, the healthy intact skin will not penetrate any microorganisms, whether it is a COVID virus, whether it's HIV virus, whether it's influenza virus, any microorganisms. So the maintenance of healthy skin, it's the crucial to prevent entry of microorganisms. And the second one, it indicates the underlying systemic infection. That means skin is a marker of systemic disease in certain conditions. That also we are going to see some cases. And not only that, it is an indicator of immune system function. For example, if the patient is immunocompetent, what are the types of skin diseases? In early immunodeficiency, what are the types of skin diseases we will come across? In advanced immunodeficiency, what are the type of skin diseases which we will come across? And not only that, it is an indicator of drug reactions, adverse cutaneous drug reactions. Generally, immunocompetent individual, the incidence of adverse drug reactions are less. Whereas immunocompromised, the incidence which will increase, and that also we are going to learn in subsequent slides. And recognition of certain skin-related immune reconstitution inflammatory syndrome after starting of ART, that is iris. So when, for example, if the person is suffering with TB and HIV, so we have to first treat with the TB and subsequently we have to give ART. Otherwise, because of the reconstitution of immune system, that person may going to develop iris. As we know, the whole world is running towards two things, health as well as beauty. For health and beauty as well as survival, the important organ is healthy skin. So for the healthy skin, the moist is mandatory. No moist, no living kingdom, no skin health, no genital health, no beauty, and no body health. So the people, those who are presented today, I request everybody, please sensitize the importance of healthy skin from the pediatric age group, from the day one. So our body, our skin, healthy skin is like a kavacha kundal. So let us sensitize more and more the importance of healthy skin by regular physical activity and taking balanced diet. Because healthy skin is healthy child and healthy body and subsequently healthy nation. Unless until the nation is healthy, the nation will not develop from developing into developed country. It's a responsibility of every healthcare provider see that the maintenance of healthy skin for the progression of healthy nation. So these are the spectrum of dermatological conditions directly related to the CD4 count. If you see in the seroconversion, what is that HIV exanthem? The diagnosis of HIV in these conditions is very difficult. So this also we are going to learn in subsequent slides. But when the CD4 count is above 500, so the tinea, psoriasis, seborrheic dermatitis, that we will come across in immunocompetent individual also. But how we are going to differentiate, how we are going to predict these type of lesions in a immunocompromised, like in early immunodeficiency. Whereas in intermediate, again, so you see the bacterial folliculitis, something related, as I said, the air follicle related infections like folliculitis, furuncle, carbuncle, they will be a little bit deeper, needs the specific course duration with the dose and duration is mandatory. Whereas in advanced immunodeficiency, where we'll see the opportunistic infection. The opportunistic infection means These organisms are ubiquitous all over the world, but they won't produce, they won't multiply, and they won't responsible for clinical manifestations in the immunocompetent individuals. But when there is a immunocompromise, whether it is HIV infection or primary immunodeficiency or any renal transplant or any prolonged course of systemic steroid there, immunosuppression, that gives rise to there is a opportunistic infection that also we will learn in subsequent slides. See, you see, this slide is very important. These are the cutaneous disorders. These are the indicator for HIV testing. You cannot write HIV testing for all the patients. You need to explain based on these features. I am going to write the screening for HIV. So exanthem of seroconversion. So it is an indicator, but the ELISA test will not help here. But the viral load along with the symptoms of signs of the clinical will help. Oral candidiasis. This also is a screening for HIV testing. Oral hairy leukoplakia, recurrent herpes zoster, chronic herpetic ulcers, seborrheic dermatitis, pruritic papillary eruptions, multiple molluscum contagiosum, any STIs. So these are the indications for screening. We will discuss in detail in the subsequent slides of each one. Yeah, so we know these are the skin conditions. Generally, the infections caused by bacteria, viral, fungal, or parasitic, inflammatory conditions, cutaneous malignancies, miscellaneous. For this, what we need to do, remember this our tricolor beautiful flag to approach. First thing is, what is a type of skin condition, whether it's infective or inflammatory condition. Second thing, assess the immune status based on the type of whether the opportunistic infections we are seeing and non-opportunistic infections we are seeing. The always assess the immune status based on the type of skin conditions if it is feasible. And how do you manage? Always we need to treat the patient whether it is HIV positive or negative. So the management with HIV would different from non-HIV individuals. So these are the infective conditions. You could see the bacterial, viral, fungal, and orthopedic. In the bacterial infection, this folliculitis, furuncle, ecthyma, abscess, these are commonly seen in immunocompetent also. But some bacterial infections like bacillary angiomatosis or atypical mycobacteria is specific for immunocompromised individual. Whereas in viral infections, you could see all type of viral infection, but oral hairy leukoplakia is specific for immunocompromised individual. Whereas fungal infections, as I said, the opportunistic fungal infections always is the indicator for the HIV screening, like penicilliosis, cryptococcosis, histoplasmosis, or in arthropod, demodex folliculitis that we will see in subsequent slide. If you see the infection skin conditions related to the HIV in early immunodeficiency, compared to immunocompetent, they're common just like immunocompetent. But remember the recurrence. Recurrence is the key. For example, any common skin conditions, if you see recurrence, we have to look for either primary immunodeficiency or secondary immunodeficiency like HIV/AIDS or diabetic conditions or any renal transplant. And generally, they self-heal, clinically indistinguishable from immunocompetence. But the point is recurrent bacterial or skin infections, if you see, again, though the dermatology is a surface medicine, but the vision should be beyond surface medicine if you see recurrent type of skin conditions. And in advanced immunodeficiency, generally it is not a problem for the diagnosis, because remember 3 P's, PQ with A, persistent skin conditions, painful, painless will become painful conditions, or progressive in spite of treatment, or atypical manifestations, non-healing. Always these are the features of advanced immunodeficiency. So remember this in the early to approach the skin conditions in immunocompetent and immuno. So inflammatory conditions. So you could see the zeros and icthozerosis is common even in the winter for everybody. But in the zerosis immunocompromise, it is irrespective of season, it will be there throughout the year, predominantly in the lower limbs. So that's one clue. And eosinophilic folliculitis, generally folliculitis is generally painful. Here, eosinophilic folliculitis is associated with intense itching. Folliculitis means the inflammation of the hair follicle, generally which is painful. If it is associated with intense itching, you have to suspect eosinophilic folliculitis, where it is need the required screening for HIV infection. And cutaneous malignancy like apoptosis, non-Hodgkin's lymphoma, we'll discuss. And adverse cutaneous drug reactions, acute xenocarcinoma, PP, pruritic papillary eruption, that we will see with the pictures. So what is the diagnosis? This is the infection of the hair follicle. What do you say? Mostly it is staphylococcal. So remember, between staphylococcal to staphylococcal is a localized infection. Streptococcal, the associated with the lymphatic involvement, so there is a spreading, dissemination. So mostly this is skin and soft tissue infections are mostly by Staphylococcus aureus. But you could see if it is confined the inflammation of the hair follicle, you could say the folliculitis. So together the multiple folliculitis, the interfollicular area is furuncle with the subcutaneous inflammation, carbuncle, the cellulitis is the inflammation of the subcutaneous tissue also. The impetigo, generally the pyodermas is the follicular pyodermas and non-follicular. Non-follicular, generally there is impetigo and ecthyma. There is nothing linked with the hair follicle. The link with hair follicle is follicular pyodermas, as I said, folliculitis, furuncle, carbuncle, cellulitis. This is the, in general, it can be seen in all, any either immunocompetent or immunocompromised. But if you see the recurrence, always you have to go for the assessment of the immune status. Yeah. So as I said, the bullous to non-bullous impetigo. So this is the non-bullous impetigo. Is a honey color crust is the key. Generally, in the pediatric age group, you could see very frequently. But if you won't treat properly with the inadequate dose or incomplete dose or in no treatment, then there is a risk for the renal involvement in the form of acute glomerulonephritis, where the child with the pyoderma, the impetigo contagiosa, then child will have reduced urine output, red color urine, sometimes throwing of convulsion. So non-emergency will give rise to emergency. Whereas the bullous impetigo, if you won't treat, that can give rise to staphylococcal scarlet skin syndrome. So as I said, related to hair follicle, ecthyma, non-follicular deep-seated infections, this non-bullous impetigo contagiosa. So how to treat? First, you identify the any triggering factors like anemia, diabetes, immune status, if you see the recurrence. And the dose for this pyodermas is generally bullous impetigo topical therapy is not sufficient. It will not work because it is toxin mediated. Whereas where we have to give the anti-staphylococcal therapy 30 to 50 mg of either cephalosporin group or ampicillin cloxacillin group 3 times in a day minimum over a period of 7 to 10 days. But in my practice, what I will do 5 days beyond the clinical clearance. Whereas the non-bullous impetigo, mostly it is streptococcal infection. Again, either penicillin group of drugs or cephalosporin should be given over 7 to 10 days. But here, if it is mild, topical antibacterial creams may help. But in bullous impetigo, there is no role of topical therapy because it is a toxin mediated. So this is a treatment as well. So anything related to the hair follicle, whether furuncle, carbuncle, it needs a little bit prolonged 7 to at least to 10 days or 7 to 14 days is required. And when the abscess or carbuncle is there, the incision and drainage with the help of surgeons. So if you see this type of nodules with systemic symptoms, like with systemic findings, like fever, weight loss, night sweats, weight loss, anemia, along with the small red papules that gradually expand into large papular or nodular or pedunculated lesions, you have to suspect beyond the skin in the form of bacillary angiomatosis, where you could see in immunocompromised individuals is necessary for the screening. Where generally this is caused by Botulella bacteria organism, Botulella ensilae or Botulella quintanilla, especially for peaches. And the treatment is general erythromycin 500 mg oral 4 times in a day, or doxycycline 100 mg oral or IV for 3 months. Alternatively, azithromycin 500 mg orally once in a day, and assess the immune status, and if it is required, the antiretroviral therapy according to the CD4 count, we have to go. Whereas if you see the mycobacterial infections, the scrophaloderma generally on the bony prominence and lymph nodes, the cold abscess, generally the hot abscesses which caused by the Staphylococcus strepto, cold abscess, mycobacterium tuberculosis, or scrophaloderma, any lesions which is developing with undermined edges, we have to rule out mycobacterium tuberculosis. So for this, generally we need to give the specific ATT along with the supportive and symptomatic therapy. So the lupus vulgaris, scrophaloderma, tuberculosis, these are the skin manifestations which is caused by Mycobacterium tuberculosis. Whereas Mycobacterium avium intracellular is generally in immunocompromised. The hemophilus rarely present with a cutaneous substance ulceration. When if you see atypical Mycobacterium, always you have to consider the immune status and respond accordingly. Syphilis, actually, the syphilis which is caused by the leptospira organism, which has ruled almost double the British people. 400 years, the syphilis has ruled the globe. But we should say, for thanks to the penicillin who has discovered, with the penicillin treatment, so the incidence of the syphilis has come down. But there is a research because of HIV infection. So if you see any painless lesions, we know the syphilis is a primary stage, secondary stage, tertiary stage. Generally, primary syphilis, there could be a painless indurated chancre in the genital area with a painless lymphadenopathy. Whereas in a secondary syphilis, which is highly infectious, generally you will see the bilateral symmetrical asymptomatic rashes with the involvement of palms and soles. Always you have to consider the secondary syphilis. Generally, in immunocompetent, first stage will shift to the second stage. But in immunocompromised, you could see the chancre as well as primary and secondary together. You will see the painless chancre in the genital area and the painless maculopapular rash on the palms and soles and the trunk. So that always you have to search for the immune status to rule out HIV. And if generally in immunocompetent, the chancre is painless. If painless will become painful and the single will become multiple, always you have to rule out the immune status, especially the screening for HIV. So these are already I told. The treatment is what we are following here. If immunocompetent individuals, in early syphilis, single dose of benzathine penicillin 2.4 million units intramuscularly should be divided on either side. It should be given after test dose with a proper breakfast or food. Whereas immunocompromised, irrespective of the earlier late syphilis, we need to give 3 doses of benzathine penicillin 2.4 million units per week for 3 weeks. That's what we have learned from our teachers. So if you see secondary syphilis, the painless lesions. In acute retroviral syndrome, there also the maculopapular rash with the involvement of palms and so on. But you could see the multiple mucosal involvement, the mucosa, enanthema of oral mucosa, enanthema of conjunctiva, enanthema genitalia, that will go. Whereas in acute cutaneous drug reactions, There also maculopapular rash, which is there on the palms and soles. But here is the itching, severe itching is the future. It would go in favor of adverse cutaneous drug reaction, where in secondary syphilis, those rashes are asymptomatic, painless, no symptoms. So that is a way we have to differentiate from the secondary syphilis to adverse cutaneous drug reaction. Coming to the fungal infection, oral candida. The candidiasis, as I said, the candida albicans is a normal commensal in our body in the genitalia and cutis. First 6 months, the candidiasis is oral thrush. It's a physiological condition because of the prematurity of IgA antibodies. Generally, if you give the topical antifungal, so over a period of 7 to 14 days, generally it will disappear. But persistent beyond 6 months of oral candidiasis, always you have to look for the immune status, whether primary immunodeficiency or secondary immunodeficiency. Whereas adults, if you see the oral thrush, it is the indicator for screening. That is a WHO clinical staging. But along with this oral thrush, if any person, any patient who is suffering with difficulty in swallowing, always look the uvula. Any white spots which are there on uvula, it is a AIDS defining illness. You could see the endoscopy, the white patches, the oroesophageal candidiasis, that is a WHO clinical staging 4, where you initiate the ART without looking for the CD4 count. So that is a way you have to differentiate from oral candidiasis, oroesophageal candidiasis. Oral candidiasis is the clinical stage 2, whereas the oroesophageal is the stage 3. So the treatment, as I said, always you address the immune condition, based on that you treat. And antifungal therapy, generally topical antifungal such as clotrimazole 1% cream or ketoconazole 2%, or fluconazole 100 mg or 3 to 6 mg per kg per day in children, orally once for 10 days. Generally, along with the good nutrition and look for the immune status, respond accordingly, and give antifungal therapy for the candidiasis. So tinea, the tinea dermatophytic infection, which is called by the dermatophytic infections of the trichophyta and epidermophyta and microsporum species. Generally, some may be zoophilic, geophilic, anthropophilic, but now we are facing the epidemic of dermatophytic infection, mainly because of misuse of topical steroids with the topical antifungal therapy without consulting the specialist doctor directly. They are going to the medical shop and taking the medicine, and the disease which is expanding. But if you see extensive the fungus like a ringworm infection or dermatophytic, always you have to look for immune status. You have to look for any misuse of topical steroids. In even some quacks, they prescribe the systemic steroids for this dermatophytic infection, the secondary immunosuppression that will give rise to extensive the tinea infection. If this is there, so you need to give specific therapy of antifungus. Antifungal therapy, where you have to give the general measures as well as specific therapy with antifungal like itraconazole or terbinafine based on that. But if you see extensive therapy, always take the help of dermatologists wherever you are. Even if the nail, generally it won't involve. If you see the proximal onychomycosis, always it's an indicator for HIV screening. The tinea infections, always take the help of dermatologists. So that general measures is also very, very important. The topical therapy follow rule of 2. What does it mean by rule of 2? Generally, antifungal therapy should be given 2 times in a day, and 2 weeks beyond the clinical clearance, and 2 centimeters beyond the lesion. If lesion is like this, 2 centimeters beyond the lesion, because we need to address the subclinical inflammation of that particular condition. So if any doubts are there, so I will be happy answer during the question answer time. Even the fungal infection, the Tinea versicolor is Malassezia furfuris organism responsible for pityriasis versicolor, seborrheic dermatitis, and pityrospora folliculitis, which is folliculitis generally painful, whereas eosinophilic and pityrosporum folliculitis, they are mostly itchy, but the itching is not much, not intense like eosinophilic folliculitis. So the treatment generally, the problem is the pigmentation. To resolve, it will take months together. That you need to explain. So the selenium sulfide shampoo applied and left for 30 minutes and then washed off daily for 1 week. A topical imidazole applied twice daily for 2 weeks, or oral itraconazole 200 mg daily for 1 week for resistant or widespread infection. Remember, the pigmentation takes months to return to normal. But the question will be arise, the patient may ask, doctor, you have given the treatment, but my pigment, I want to know that my disease has gone or not. So generally, with treatment, the scale will disappear and the satellite lesions also will disappear. And if you do KYH, generally positive will become negative. But the hypopigmented macules, which remains for months together, that you need to explain before initiation of treatment, because the patient may follow the instructions of anybody if they are symptomatic. But once if they are asymptomatic, they won't follow the instructions of healthcare provider, how beautiful you are, how handsome you are. So that's why before initiation of treatment, or I am going to treat you, but the pigmentation which will remain for 3 to 6 months, then only it will resolve, but infection would go over a period of 4 to 6 weeks. And as I said, systemic or deep mycosis may be penicilliosis, cryptococcosis, histoplasmosis, porotrichosis. These are all are opportunistic infections. Generally, you won't see in an immunocompetent individual. If you suspect, always take the help of dermatologist and go for screening. And the treatment has to be given with a proper dose and duration over a period of months. And the talaromycosis, the centrally necrotic papules umbilicated here, the cryptococcosis. So mostly these are umbilicated skin papules. We heard about, now we are seeing the umbilicated vesicles. Now it's becoming, seeing so many cases, umbilicated vesicles on the trunk of the body, more predominantly in the children's, nothing but chickenpox, varicella. But umbilicated papules, if you see, whether it is simple molluscum contagiosum, or because of talaromycosis or cryptococcosis or histoplasmosis, it is the responsibility of healthcare provider to differentiate. That we will see in the next slide. So you could see here the skin manifestations of talaromycosis, nothing but penicilliosis, which is caused by the tularemia or Penicillium morniferae. You could see molluscum contagion, there is umbilicated papules, but there is no systemic symptoms. Whereas penicilliosis, the person generally mostly will see in the northeast states like Manipal, where the people, the farmers who are working in the bamboo stick agriculture, where the Penicillium mornifera or Tularemia mornifera, which is the organism common habitat. If you see umbilicated papules with anemia and the hepatosplenomegaly, you have to suspect penicilliosis. Whereas any person who is suffering with fever, which is not controlled, become comatose, throwing seizures, and admitted, and signs and symptoms of neck stiffness, and later they develop umbilicated papules, secondary. So that gives a clue to think of cryptococcosis. Here, skin acts as a marker for the screening of systemic disease. Generally, systemic symptoms with CNS with umbilicated papule. Just if you do Indian ink preparation, you could see the Cryptococcus neoformans organism. That is nothing but cryptococcosis. It's in an advanced immunostatus, immunocompromised conditions. You need to treat this as well as immune status. Whereas histoplasmosis also the hematological conditions with umbilicated papules. So this is a way you have to identify, especially for the PGs. Generally, this will be asked questions how you are going to differentiate if you see umbilicated papules between molluscum contagion, which is caused by molluscum DNA virus, and remaining are the opportunistic fungal infections. Coming to the viral infections. So the human herpes virus HSV8, which is caused by the HSV8 seropositive and exhibit HIV viremia, or increased risk of development of Kaposi sarcoma almost 9-fold. In endemic areas, the soles, lower limbs are commonly involved. In epidemic Kaposi, generally the soft hard palate and the head is commonly involved. You could see this Kaposi sarcoma associated. Fortunately, in immunocompetent, you won't see immunocompromised. Generally, you will see, fortunately, less commonly seen in India. So we have different types of all the pulmonary, lymphatic, oral, all is there. The diagnosis mainly by cytological and immunological cell markers as well as histology will give a clue. You could see here, Kaposi sarcoma, this is the early red, blue, or dark purple flat macules. The lesions become lobulated as the disease progresses. So Kaposi sarcoma is one of the AIDS defining skin malignancy. Fortunately, it's rare in India, but which is not uncommon. So the treatment is in early stages, you could ART sufficient, but if in advanced conditions, you should go with the chemotherapy. I won't go in detail. So it is there in the books. Coming to the herpes simplex HSV1 and 2, HSV1 is generally the orolabial herpes and 2 is caused by genital herpes. So more than 95% of homosexual men with AIDS have a history of HSV infection. The HSV shedding occurs more frequently when the CD4 count less than 200 per cell cells per cubic millimeter. Significant cause of proctitis in men with HIV infection who have sex with men, MSM. So the manifestations of non-mucosal HSV infection, the HSV keratitis, HSV encephalitis, and hepatitis, herpetic vitiligo, there are different varieties. Even so, the herpes infection in immunocompetent, it's a benign. Herpes infection in adults, immunocompetent, it's a benign. So even if you give treatment or if you won't give treatment over a period of 7 to 10 days, it will be, all lesions will be clear. But herpes infection in neonates, you need to treat with specific therapy with acyclovir. Herpes infections in atopic individuals, you need to treat with specific antiviral therapy. Herpes infection in immunocompromised, you need to treat with specific therapy. That is, remember, 3 conditions. Neonate. So in the neonate also, we have a SEM type, skin, eye, mouth type, and the CNS type and disseminated type. In the SEM type, first week you will see SEM type. In the second week is the CNS type, and the disseminated you will see in the third week. And in the herpes infection, we have a primary infection, latent infection, reactivation. So the primary host acquires infection for the first time. The future of herpes group of infections, once if it is infected, the virus which will remain life in that organism, but which are in the latent phase, somewhere in the dorsal ganglion. But whenever the immune status is compromised as age progresses, then the reactivation of this virus and produces the clinical manifestations. So, but unlike even in HIV virus, once it enters into the body, it remains. But the HIV virus, destroys our police system, that immune system of CD4 cells, CD4 T lymphocytes. That's why we are prone for life-threatening opportunistic infections and malignancies. Whereas in HSV infection, there is a reactivation of the same herpes infection, but immunocompromised again. So it needs a prolonged treatment to prevent continuous multiplication of this virus to produce the persistent of the skin lesions. So the treatment, as I said, before treatment, atypical herpes, generally in immunocompetent, it is a classical multiple grouped discrete vesicles and erythematous base over a period of 2 to 3 days, their erosions, and 7 to 10 days, it will resolve. Whereas it converted into ulceration. Generally, herpes infection, only the erosion is confined to the epidermis. Ulcer, it is beyond the epidermis, enter into the dermis, second layer of the skin. Whereas erosion will become ulcers, that is atypical, and generally which is persisting. So atypical herpes infection, so it is a WHO clinical stage 4, where we need to screen and initiate the therapy. Even the CD4 count, which is not available in the remote areas, based on the WHO clinical stage, we can initiate ART. As I said, herpes infection over a period of 7 to 14 days, it will resolve. But persistent beyond 1 month, or herpes infection associated with visceral involvement, again, it's an indicator for HIV testing. So chronic herpes simplex infection with lesions on tongue and lips persisting more than 1 month, or visceral involvement, you have to screen and respond accordingly. So the treatment in the generally early primary infection 7 to 10 days. Recurrence generally 5 to 7 days. Acyclovir generally 400 mg 3 times a day, whereas valcyclovir 1 gram orally twice a day, or the management of genital ulcers also. Remember the primary infection recurrence. Primary infection 7 to 10 days. Recurrence generally 5 to 7 days. Whereas immunocompromise, generally it requires the double the duration. The dose is the same, but duration you need to give recurrent infections. You need to give rather than 5 days, you have to give 10 days. Whereas primary infection for 7 to 14 days. In a resistance conditions, you can go with the foscarnet 120 mg per kg per day. So as I said, the neonatal infection, even we have seen 2 cases. One case, if you miss the diagnosis or if you delay the diagnosis, there is a mortality. Always, if you see multiple grouped vesicles or multiple discrete vesicles in the neonate, immediately you do the Jank test and send for serology. And so you start acyclovir 20 mg per kg per dose 3 times in a day over a period of 7 to 10 days. If it is CNS or disseminated, the 14 days and 21 days you have to give. Coming to the herpes zoster. Herpes zoster also immunocompetent to immunocompromised. So herpes zoster, again, it's a marker of systemic disease. Generally in immunocompetent, single dermatome, single episode, no hemorrhagic, no recurrence. Whereas immunocompromised, there is a bidermatomal, multidermatomal, bilateral, recurrent, hemorrhagic. Always rule out immune status. So you could see generally immunocompetent, the rare in immunocompetent children. In adults, as age progresses, we'll see. Whereas in immunocompromised, the incidence almost 9 times more with HIV individuals. The coming to the generally, we know the varicella zoster virus, the primary infection is varicella, and recurrent in reactivation is the varicella zoster virus, that is shingles or herpes zoster. So generally it is a prodromal, dromal, and postdromal. What do you say? Post-herpetic neuralgia. So you could see even eye involvement, zoster ophthalmicus. Always it's a you need to treat immediately, otherwise we may lose the vision. So the management is clear. The treatment duration 7 to 14 days. You can give valcyclovir 1 gram TID or famciclovir 500 mg TID or acyclovir 800 mg 5 times a day. So the adherence to the patient, if you give, you advise 5 times. If they are well and good, you can give acyclovir. The safety of margin for all 3 drugs is good. But prophylaxis, it won't work. The management of herpes zoster ophthalmicus. So with you can take the help of ophthalmologist also. That has been treated with the antiviral therapy. So this already I told, the acyclovir is the treatment of choice in resistance condition. So postcarnet. So if you see this child at presentation, the no prodromal. Fortunately, the prodromal symptoms are more in adults, but children's herpes zoster prodromal symptoms are less. So this child, herpes zoster, ophthalmicus. So we initiated treatment after 1 week. You could see here. Then after 2 weeks, so all lesions were subsided. Fortunately and luckily, there is no loss of vision. So what is the story of this? This child is HIV positive. The CD4 count is 216 and herpes zoster ophthalmicus. The child was put on acyclovir. So for the 800 mg 5 times in a day, because which is available in our hospital, is free of cost. So when you see zoster ophthalmicus, don't be panic. So you do counseling to the patient and you advise that if you take proper treatment with dose and duration, definitely the all lesions will subside, because the fear is the enemy. So always you remove the fear by proper counseling and along with the medication. So if anybody is interested, even we have done a study, the prospective study of herpes zoster in children, which is published in IJD. So you can go through in detail. So what was known, herpes zoster in children implies immunodeficiency or malignancy. But what we have proved, the presence of herpes zoster in children is not immunocompromised, not immunodeficiency. It can be seen immunocompetent also. But so we have to rule out immune status when you see herpes zoster in a child. Whereas if you see, so this is extensive, this is a cognition, the flat, the verrucous lesions. The diagnosis is not a problem, verruca vulgaris, which is caused by the HPV, human papilloma virus. So if you see extensive, again, it's a indicator for HIV screening. Here, the medical therapy will not work. The cauterization, whether the chemical cautery, electrocautery, or cryocautery, along with the addressing the immune status, if it is necessary, based on the CD4 count or WHO clinical staging, we need to treat. And children, so in the perianal warts, if you see in children, remember 3 things. Whether it is first is auto-inoculation, or it is because of sexual abuse in a children, especially the girl woman and the girl child, or because of the sexual intercourse. When you see the warts in the genital area, the next step is rule out sexual abuse, and second point, rule out immune status, whether immunocompromised or immunocompetent. If it is immunocompetent, then what we have done a study, we have given the intralesional MMR therapy. So just if you give 1 or 2 lesions, all lesions will be subsided. But in immunocompromised individuals, please don't give MMR. MMR is a live vaccine. So you go for any cauterization, then based on the CD4 count, address accordingly. So as I said, the cauterization is the treatment of choice. The molluscum contagium, as I said, one is the DD with the systemic symptom. Another one is the molluscum contagiosum. If it is present on the face in adults, it is an indicator for the HIV screening. Always you have to rule out immune status of the child, adult. Whereas in children's, molluscum on the face in a child could be auto-inoculation. So no need to go for screening in all children if you see MC on the face in a child. But giant MC on the face, even in a child, the giant means more than 1 centimeter. So then itself is an indicator for HIV screening. So as I said, the treatment is the cauterization, with a cryocautery or electrocautery or chemical cautery, along with the ART accordingly. So oral aeroleukopiliaceae, as I said, just like a candidiasis. How to differentiate? First thing, if you see white patch on the tongue, how to differentiate? So this mostly this is caused by Epstein-Barr virus infection, exclusively occurring in the immunosuppression. More than 25% of PLHIV develop oral hairy leukoplakia at some point. Can occur at any level, but it's more common the CD4 count less than 200 per cubic millimeter. Possibly one of the first sign of development of AIDS. So if you see the white patch on the tongue, preferably on the lateral, you rule out whether it is a candidiasis or oral leukoplakia. How we are going to differentiate? If it is if you scrape the lesion, generally if you see on the lateral side, mostly oral leukoplakia, on the dorsum candidiasis. But if you scrape it, while scraping, if you can't remove any scale, that is oral hairy leukoplakia. If it is candidiasis, you could see some bleeding spots. That is a way you can differentiate from candidiasis to oral hairy leukoplakia. Oral hairy leukoplakia is AIDS defining illness. So white linear vertical raised lesions over the side of the tongue, and they are not easily removable, which is caused by Epstein-Barr virus, which is a WHO clinical staging 3. So this is all I have already explained. So the diagnosis is mainly clinical diagnosis confirmed by EBV is identify oral lesions by electron microscope. Treatment usually does not require treatment. ART is sufficient to clear all the lesions. The tretinoin and podophyl the resin can be applied directly to the patches. Liquid nitrogen cryotherapy and surgery are other alternatives, but if you address ART, that will come down. So this is another case, severe intensely itchy condition, crusted lesions in a patient. So again, this is an indicator for HIV screening. So this is nothing but crusted scabies. Generally, scabies, you won't see the crust. But in a HIV individual or immunocompromised or leprosy patients or neuroparalysis patients where the mites would be almost millions. Generally, in immunocompetent, the scabies only will see the web spaces. But in the crusted, each crust, if we remove, you will see the millions of the sarcoptic scabies mite. Here, the topical therapy is not sufficient. If you see like this, you do screening for HIV, and if it is positive, they look for CD4 count and treat the scabies also with the topical as well as systemic therapy. The 200 micrograms per kg, that is around 12 mg of ivermectin should be given a start dose. If it is required, repeat after 2 weeks along with the permethrin of topical therapy, and the crusting scaling should be removed and with the proper emollients. The inflammatory conditions. So the increased generally I said dryness, xerosis could be there in all our. The treatment is emollients, proper diet, plenty of water. The emollient should be given. The steroid generally is not required for xerosis condition. The seborrheic dermatitis. So it is one of the most common inflammatory dermatosis observed in children living with HIV, occurring with rates of up to 83% as compared to 1 to 3% among immunocompetent children. So it is the most severe, the more severe in late stage of disease, because Petrospora malassezia furfur, which is a normal commensal. Immunocompetent, it won't multiply. Immunocompromised, it multiply and responsible for the scaling. So generally it clears as immune function improves following with the ART. Just give emollients if it is itching, antihistaminic and ART. In mild topical steroids, shampoos can be tried, but emollients and antifungal topicals is sufficient. The cutaneous malignance, suppose I said, the non-Hodgkin's lymphoma is another entity. So generally treatment with chemotherapy, chop regimen. You could see here the painless multiple nodules. If you see like this, generally in males, PLHIV 38%, in females almost 16%, almost 17 times risk in males, whereas 10 times risk in females. Coming to the miscellaneous, as I said, the adverse cutaneous drug reaction. So it could be a simple eruptions or complex eruptions like SJS, TN, or overlap. So a few points related to drug reactions. The simple eruptions, generally, the incidence would be 2 to 4 times more in a immunocompromised. Whereas severe adverse cutaneous drug reaction like SJS, TN, the 100 to 1000 times more in patient with HIV, because the HIV is the most common cause of the significant reduction of glutathione peroxidase and glutathione transferase. Those are the enzymes responsible for detoxification of the medicine, and which these two enzymes has been suppressed by this HIV virus. So in advanced disease, the viral load is very high. So the suppression of these two enzymes is almost maximum. So the incidence, that's why the incidence 100 to 1000 times more in a severe cutaneous adverse drug reactions like SJS and TOA. So how do you manage? In a mild form, just give emollients and antihistaminic with the help of dermatologist in moderate. So if the patient is on ART, so with the consent of dermatologist to stop or not to stop. If it is severe, definitely you have to stop all treatment. You have to switch over to next modalities of treatment or another regimen which is not responsible for this drug rash. And when you see the severe reactions, always needs for hospitalization, because almost is like a skin is compromised, prone for allergies, prone for infections, barrier repair is required, and the fluid and electrolyte loss would be there. So these all should be addressed. So you could see all the different types of all. So if simple, this patient, this both child and father both are HIV positive. So they came to us. So immediately the simple eruption, initially first 10 days there is a simple eruption, no fever, no systemic symptom. They came to us, immediately we stopped the treatment, we have given simple emollients, antihistaminic, all lesion was subsided after 10 days. So then we restarted. And the another child, this HIV only, so they continue the treatment without, they went to private, some quacks, RMPs, they have given treatment, they didn't diagnose it's adverse cutaneous drug reaction, they advised continue the treatment, and they have continued and they landed into SJS. So how early you diagnose the culprit, how early you stop, and how early you initiate the supportive and symptomatic therapy, that matters, and that prevents the mortality as well as morbidity. So the treatment, if it is severe, the supportive therapy according to along with the immune status we have to address. The pruritic papillary intense itchy conditions, hyperpigmented, predominantly on extremities. It is again the think of pruritic papillary eruptions. It's again indicator for screening. Not only that, it is a prognostic marker. So the classical therapies are systemic antihistaminic, or in severe condition oral prednisolone for short therapy of anti-inflammatory dose less than 1 mg per kg, topical corticosteroid preparation, but more effective is the exposure to UV therapy. And thalidomide can also be tried, but it is mainly given for leprosy patients. So the pruritic papillary eruptions 11 to 46% incidence, and the treatment as said topical therapy, emollients, antihistaminic. And acute retroviral syndrome is where this the ELISA test will be negative, but HIV, the viral load will be more than 50,000. Along with that, asymptomatic maculopapular rash with multiple enanthem, multiple mucosal oral involvement of oral mucosa, conjunctiva, genital mucosa. Always we have to suspect acute retroviral syndrome. Yeah. So to sum up, the clinical stage 3 of related to dermatology, oral candidiasis, if you see. So clinical stage 3, WHO clinical stage 3 and 4 is the initiation for ART. Whereas 2, majority of dermatological conditions in the WHO clinical stage, where it is the prediction for the screening of the HIV status, especially if you see the recurrence. Oral aeroleucoplakia and acute necrotizing ulcerative stomatitis, the WHO clinical stage 3. Whereas 4, the atypical HSV infection, chronic herpes simplex infection, which is persisting more than 1 month, oroesophageal candidiasis or extrapulmonary tuberculosis. These are the HIV clinical. So these 4 and those 5 conditions where without CD4 count you initiate the ART. So take home is always, I used to tell to my PG, history is the king in the field of medicine. History and history. You spend time with the patient will give number of clues to come to a conclusion of diagnosis. And detailed examination is very important. And third, always when you treat, implement formula of M square. What it is, if it is pre-adolescent, totally they are depending on the parents. always along with medication, you involve the mother or caretaker in the initiation of treatment. Because so as a doctor, my role with the medication is 50%. But as a mother or caretaker, your role is to give properly with the proper dose and duration without any interruption with a supportive therapy. Whereas adolescents, remember adolescent, neither they are children nor they adults. They won't follow the instructions of anybody, whether the mother, father, doctor, teacher, student, whoever it may be, unless until you involve them in the treatment, they won't follow. So that's why medicine and mind of adults, adolescent and adults also. You involve the minds of adults, you do counseling. So this is a way if you take proper treatment, because now the HIV is no more a death sentence. AIDS is no more a death sentence. AIDS is a chronic manageable disease. So if you manage, so especially the nutrition, undernutrition. So if you even HIV infection to postpone AIDS, you need to prevent NAIDS. NAIDS is nothing but nutritionally acquired immunodeficiency syndrome, where severe malnutrition is responsible for immunosuppression and subsequent rapid progression of HIV infection to the AIDS. So finally, the HIV AIDS is burning social issues. No skin condition is specific to HIV, but more than 90% of HIV infected patients develop skin and mucous membrane. Certain skin condition can predict the presence of HIV. The chronic, as I said, 3Ps with the A is the indicator for advance. Malnutrition is one of the major complications HIV infection. That's why I told. So if even HIV infection is there, so if you prevent NAIDS, you can postpone AIDS. And nutritional status affect the HIV disease progression as well as mortality. The insufficient antioxidants from increased utilization causes oxidative stress in HIV replication, leads to higher viral load. So human body, we know, is the longest living machine, but unfortunately without external spare parts, require fuel in the form of calories and regular physical activity for proper working and to maintain the healthy lifestyle. So with this, think it over. You have mind, use it. You have life, don't abuse it. So it's your future, it is your choice. So AIDS is a mass murderer. So with this, thank you very much for your kind attention. Yeah.
Thank you so much, sir, for facilitating this session. We have one question in the chat box. What is the best way of managing post-herpetic neuralgia? We have 4 patients who are suffering severely. The skin department people prescribed carbamazepine, but the patients are not getting relief.
The post-herpetic neuralgia, it is one condition. It needs proper counseling along with medication, because the triggering factors has to be avoided, because the pain is related to the free nerve endings. So the patient has to wear the loose cotton clothes. Excessive hot water should be avoided. Excessive the tight wearing of dresses also should be avoided. Any sounds also should be avoided. And along with that, the carbamazepine or amitriptyline should be given over a period of 3 to 6 months. Generally, it will vanish. But the proper counseling is important. What they think that it is only confined to the skin, but it is a neurological condition where the vesicles which is present on the skin and the lesions will subsided, but the neurological pain which remains for over a period of 3 to 6 months.
Thank you, sir. Sir, since you have meetings, we won't keep you waiting. Thank you so much once again for facilitating the session in so much detail. Any questions from the participants? You are requested to please write to us and we'll pass it on to sir and get the answers from sir. Kiran sir, can we have the feedback form, please?
Can I leave, please?
Yes, sir. Thank you so much, sir.
Thank you very much. Yeah.
The feedback form is now visible on your screen. You are requested to please scroll through all the 4 questions and answer them. Requesting all the participants to please complete the feedback poll. Kiran sir, we can end the feedback poll now. Thank you to all the participants for patient listening. Any questions on this topic, please write back to us and we'll pass on the questions to Dr. Bhumesh sir. The next session will be held on 18th of April. That's a Tuesday. And the topic is non-communicable diseases and mental health, prevention, screening and management among PLHIV. Thank you.